All right, so we're going to finish up spines today. We're going to do L-spine, sacrum, and coccyx. So those are all the views that we're going to talk about. We're going to talk about obliques as well. AP of the L-spine, the image that they provided for critique is it's subtle. Um, the uh, the amount of rotation that we're seeing on the oblique. I'm going to tell you some things to look for, and we're going to look at the oblique themselves so that we can kind of see what we've got going on. So probably the most common mistake that people make in their AP of the L spine is not bending the knees. If you lay down on a flat surface, you can really tell how much of a difference it makes to bend the knees up to reduce that lordotic curvature in the L spine. Bend the knees, support the knees if at all possible. Put the hands down to the side. If you put a blanket on the patient, I really recommend that you put the patient's hands on top of the blanket so that you can make sure that they didn't put their hands across their abdomen before you make the exposure. So what you're going to look for is a number of things. You're going to look for the placement of the spinous process in the spinal canal. It should be right in the middle of the spinal column, not really spinal canal, spinal column. You're going to look for the transverse processes, and they should be symmetric. Other things that you can look for would be the appearance of the iliac wings, and you're going to assess those in the same way that we did for the abdomen. If the patient's rotated towards the left-hand side, let's say the right iliac wing would become more vertical, left iliac wing would become more horizontal or elongated looking. The sacrum and coccyx are going to rotate towards the elevated side. The transverse process on the side that you elevate towards is going to kind of tuck up under the vertebra, and we'll take a look at that on the obliques here in a minute. But if your positioning in your hospital calls for positioning at the iliac crest, you can evaluate the anterior pelvic bones possibly, um, and you could also evaluate the lower ribs. So a lot of different things that you can look at to determine whether or not the patient's rotated. So on our example here, we got slight rotation. You can see the spinous process is a little bit towards the left-hand side, so the patient is rotated. Um, it says towards the right-hand side, but it really looks to me like it's slightly rotated towards the left-hand side, so that may be a misprint. So we're going to look at rotation on the obliques and kind of assess those there, and we'll kind of look at that too on mispositioning of the obliques. So keep in mind that if your hospital calls for, your doctor, your radiologist calls for a KUB instead of an AP of the L spine on an L spine series, remember it's him who sets the protocol primarily. So if he wants a KUB instead of an APL spine, there's some very valid reasons for that. Patient may have a kidney stone with referred pain that sounds more like it's in their back than what it is in their urinary system. Same thing with gallstones, especially if you have an asthenic patient, their gallbladder may be very vertical and be really close to midline. So those could give an indication that the patient's got back pain when in fact it's a totally different organ system. So our obliques, uh, remember that your spine slowly changes from C-spine to T-spine, T-spine to L-spine, L-spine to sacrum. So you may see some textbooks refer to uh, positioning of the L-spine with different degrees of obliquities. And some textbooks may refer to obliquities as being different between the upper portion of the T-spine and the lower portion of the T-spine. So C, the L spine, upper portion of the L spine versus the lower portion of the L spine. So the upper portion of the L spine looks a lot like the lower portion of the T spine. Upper portion of the L spine looks like the lower portion of the T spine. So the obliquity for a T-spine is very steep. It's 60 to 70 degrees. So naturally, the upper portion of the L-spine in a slow transition from L-spine from T-spine to L-spine is the anatomy that we're interested in seeing is um, would be best visualized as a steeper oblique. So some of your textbooks will say if you're shooting for the upper portion of the L spine, oblique the patient 45 degrees. If you're shooting for the lower portion of the L spine, your obliquity is more like 30 degrees. So, be aware of what portion of the L spine you're looking at and what your protocol is. So, what we're looking for on the oblique is the zygapophyseal joint. So remember, on the oblique of the C-spine, what we're looking at is the intervertebral foramina. On the T-spine, we're looking at T-spine and L-spine both, we're looking at the zygapophyseal joints. So on the C-spine, if we're shooting AP, we're going to be shooting for the side up. On the T-spine, we're also going to be shooting for the side up on AP. On the L spine, we're going to be looking for the side down on AP. So what we're looking for is zygapophyseal joint, and that's that dark line right there. And how we evaluate the rotation on our oblique is by looking at the Scotty dog. Excuse me, the Scotty dog. So what we've got in the Scotty dog is the nose is the transverse process. So we got nose, transverse process. The eye is the pedicle, and then right behind the eyes, we've got the pars interarticularis, and then the ear is basically your articular pillar, as well as the foot of the one directly above it. So the foot of one and the ear of the other articulate together to create the zygapophyseal joint. So that's your superior articular process, inferior articular process, zygapophyseal joint going in between the two. So on image evaluation, what we want to see is we want to see the nose of the Scotty dog right up at the very edge of the vertebra. So the one that we're looking at there is the side closest to the image receptor. So if we're rotated towards the patient's right hand side, as what we're seeing here, the right transverse process should be right at the edge of the vertebra. So if your nose is sticking out from under the body of the vertebra, it means you're not lateral enough. You're too AP. If on the other hand you're under or over rotated, then your nose is back inside of the body. Right? So you want the nose right at the very edge of the body. It actually looks like they're ever so slightly under rotated here. I wouldn't repeat this, but it does look like the nose is sticking out just a little bit. So where you can position is just medial to the ASIS, which would be right about there. You can feel for the angle of the ribs right there. But on the image, what you see here is the ASIS. So if you feel for the ASIS, just go medial to that, and you should wind up pretty much right on the vertebra itself. Okay, so if you look at this one, this is a little bit of a mess. You see that the spine, the vertebra takes on almost a lateral appearance, and that is because they're over-rotated here. The pedicle, we're actually starting to lose the pedicle there. Instead of looking like an eyeball, it looks, I don't know exactly what to say it looks like, but it's a bit of a mess. So the patient's rotated too far. They're too lateral. You need to bring them back. So your lateral, positioning for the lateral, the probably most common mistake on positioning for the lateral is that you take a look at your patient and you have a tendency to put the longitudinal line of collimation right down the middle of the patient. But keep in mind that no matter how big our gut gets, our spine doesn't really move. So the spine, how you find the spine is if you can see this bright area right here. What that is the that's the very peak of the iliac crest. So if you can find the top of the iliac crest and put your longitudinal line of collimation going pretty much straight up and down that, your spinous process is right back here. That's going to put you right at the back of the body, but pretty much right dead square in the middle of the vertebra. So put that, regardless of how big the patient is, put that line of collimation going straight up and down through the peak of the iliac crest, and you're usually going to be good, unless you got a patient that's got a really great lumbar curvature, or if you're intentionally shooting flexion extension views. So what we want to see on the lateral is an intervertebral foramina, that big hole right there. Nice big blocky appearance to the vertebra. The most common issues in the vertebra in the L-spine would be arthritis. We see arthritis quite a bit. With arthritis, we may lose some height in the vertebra or in the disc space specifically. And what we'll see in a lot of cases is the edges of the vertebra become very bright in color because of the constant irritation. But if it becomes irritated enough, you can start to cavitate some of the vertebra and lose some actual height of the vertebra as well. Compression fractures are kind of a wedge-shaped fracture, both L-spine and T-spine. You see them a lot in T-spine, especially in osteoporotic patients. And in those patients, you get an exaggerated kyphotic curvature in the T-spine. So if you have fractures in T-spine, they're generally wedge-shaped compression fractures, and you get a exaggerated kyphotic curvature. So both C-spine and L-spine, C-spine and L-spine, common conditions would be soft tissue conditions that would take the vertebra and reduce in the lumbar spine that lordotic curvature, and in the C-spine, reduce that lordotic curvature. In the C-spine, we tend to call that whiplash, but they both manifest themselves in the same way, and that is that kyphotic curvature, or the lordotic curvature rather, goes away, and the vertebra is very rigid and straight up and down. Trina probably went through some pathologies as well, some bamboo spines, some spondylolisthesis, ankylosing spondylosis, spondylitis. But what you'll see is a incidental finding in a lot of cases. You know, the patient got in a car wreck and you shoot a AP and a lateral L spine on them because they got back pain. But what you'll see is sometimes L5 and S1 appear to be subluxed, and they are. But it's a non-traumatic subluxation. It's a normal deviation. So you know, it's maybe something that you could point out to the ER doc, but he's going to pick up on it anyway. Probably most common two mistakes on lateral L-spine positioning. One would be positioning of the central ray. Two would be rotation. Make sure that you put the knees stacked on top of each other, the shoulders stacked on top of each other. It's going to be hard not to have the hips stacked on top of each other if you did your work on the shoulders and the knees. But the other mistake is making the vertebra parallel to the tabletop. And what you see sometimes on that is that the vertebra takes on a totally different appearance. Instead of looking like a box like that, it starts looking like a drawn tube. All right, so toilet tissue is a big thing right now. So if you were to take a roller out of the middle of a roll of toilet tissue and you were to look on it straight from the side, it would, on a two-dimensional scale, it would kind of look boxy in appearance. But if you tilted it toward or away from your eyesight, you would start to see down the center of the tube. And that's kind of what you're going to see if you don't put the spine parallel to the um, to the image receptor. You're going to start to see the top and the bottom of the vertebra, and they kind of look more like a drawn tube. So sometimes if you're working in the surgery suite and they're trying to fuse a couple of vertebrae and put some screws into the lamina and sometimes into the body, is what they want to see is they want to see a perfect lateral of that vertebra. And what the surgeon may say is your vertebra is not coplanar. And what they're referring to is the appearance of the vertebra is not true lateral. So what you would need to do is adjust your C-arm so that you're truly lateral and you're not seeing the top and the bottom, the superior and inferior portion of the vertebra. All right. So detecting rotation on a patient on a lateral, first off, make sure the patient doesn't have scoliosis before you start shooting lateral x-rays over again. Evaluate your AP to determine whether or not the patient has scoliosis. This is a young patient, you can tell because the sacrum doesn't look like it's completely fused up, but this patient exhibits, if you look at the ribs, they exhibit rotation, but do they have scoliosis? That would be my first question, and you would need to look at the AP to determine whether or not the patient has scoliosis. So, L5S1 spot, generally this is an accessory view, and when we shoot it is whenever we have a patient is usually a patient who has very small hips, and I'm sorry, very normal hips. It could be wide hips, but the variable is really the waist. If you got a patient who's not got a small waist and they still got big hips, then your phototimers are going to stay on long enough that chances are you're going to get an even density on your lateral. So most of the time, in my experience, where I've had to shoot L5S1 spots the most are in patients who have narrow waist and wider hips. So what our purpose for this one is just to see the L5 and S1 spot. So you would collimate down to an area of about 3 by 3 on your entrance beam, very small area. Put your hand, what you call the heel of your hand, it's the pinky side of your hand, right above the highest portion of the crest, and fold your hand down over the crest, and the V that your hand makes between the forefinger and the thumb, that's where you would put your central ray. Keep in mind on your lateral L spines and your spots, if you don't build the spine up until it's parallel with the image receptor, then what you're going to need to do is angle your central ray caudally. That caudal angulation is going to be greater in women than what it is in men, because women tend to have wider hips and narrower waist. Men have a tendency to be more V-shaped, narrower hips. So same thing applies to L5S1 spot. If you've built everything up, you don't need any kind of an angulation, but if you did not, then you would need a caudal angulation. So we see here that we've got separation between the iliac crests, and this is what I was talking about in coplanar. The vertebra is not lateral. You can see the bottom of this L4 here. You can see the bottom of L5 there. So that's not coplanar. So what we would need to do is angle the central ray or build the patient's L-spine up a little bit. So sacrum and coccyx, the positioning for the sacrum and coccyx are the same. You put the central ray halfway in between the ASIS. You could go 2 inches below the ASIS, or you could go 2 inches above the symphysis pubis. Really, really recommend you don't palpate the symphysis pubis, but it's roughly a 4-inch difference in between the two, so you would go halfway in between. So with sacrum, your angulation is going to be cephalad. With a coccyx, your angulation is going to be caudad. All right. So cephalad, what we're trying to do is we're trying to put the central ray more perpendicular to the sacrum. So with coccyx, what we're trying to do is we're trying to project the symphysis pubis below the coccyx so that we can see it without any kind of superimposition. So the angulation is just reversed. 15 degrees cephalad for the sacrum, 10 degrees caudad for the coccyx. You're going to evaluate rotation in the same way that you would evaluate for a pelvis. And that would be to look at the iliac wings, look at the SI joints. You want to look at the anterior pelvic bones. You want to look at the position of the sacrum inside of the ring of the pelvis. So for the lateral sacrum and coccyx, you can look back on page 488-ish of your Merrills. I think this is the new edition of the Merrills, so the pages may not line up perfectly. But they give you a localization, a really good localization for where the sacrum and the coccyx is from a lateral perspective. So what Merrill says is that the ASIS, or the sacrum, the center of the sacrum, is about 3.5 inches posterior to the ASIS, and the midline of the coccyx is 2 inches below that. I've never worked in a hospital where the sacrum and the coccyx were imaged separately on lateral. As a matter of fact, I don't know that I've ever worked in a hospital that sacrum and coccyx weren't a single series. So you shot AP of the sacrum, shot AP of the coccyx, and then you shot a lateral of both. So if you happen to work somewhere where you're shooting, the protocol is separate exams for sacrum and the coccyx, then you might want to consider that positioning as separate from each other. But if you work in a place where you shoot both sacrum and coccyx on one view on a lateral, then you're positioning the center of the sacrum being 3.5 inches posterior to the ASIS would be your positioning. And what you can really do there is you could find the peak of the iliac crest and go just posterior to the iliac crest, the peak of the iliac crest, and that should get you there as well. So the iliac crest, the top of the iliac crest would be right around in here. So put your longitudinal line there and then move the patient forward a little bit, but keep the center of the image at the level of the ASIS. So positioning coccyx we just talked about, and that would be it. I'm going to open the PowerPoint for T-spine because we did not finish that, and we'll run through that just real quickly, and then I'll post this and we'll have a test on the 24th. So AP of the T-spine, the positioning for T-spine is just like a positioning for chest x-ray. The main difference would be phase of respiration. You can shoot these with the patient laying down, preferably with the patient laying down, again with the knees bent so that it reduces the curvature on the lower portion of the T-spine, that transition into the L-spine. But as far as central ray positioning goes, it's the same. So T7, for a T-spine, what we're going to want to do is shoot on exhalation, and what that does is it takes the lungs and it collapses the lungs as much as possible so that you have a more even tissue density between the upper portion of the T-spine and the lower portion of the T-spine. Evaluation is very similar to a chest x-ray, only you're not really going to be able to evaluate the ribs unless, again, your hospital protocol calls for you to use a uncollimated view of the T-spine. That's probably going to be a little bit more rare, except for in trauma situations. In trauma, a chest x-ray is your AP of the T-spine. In most routines, they're going to want you to collimate for a T-spine. So what you're going to look for is spinous process in the middle of the spine. You're going to look at the medial ends of the clavicle and their proximity to the spine to determine rotation. Make sure that you can count from the first rib all the way down to the 12th rib. And before we started using the computer algorithm, it became very important to utilize the anode heel effect. And it might still play a role, and it's still certainly a testable thing, but it's probably not as important as what it was whenever we used screens of films. And as a matter of fact, compensating filters were almost essential if you had a patient who had any kind of size to them at all on screens of films. Compensating filters, what we would do is we would put the fat end of the compensating filter over the upper portion of the T-spine, thin end over the lower portion of the T-spine to try to even out the tissue density difference between the upper and the lower. So just some things that we could do to even all that out. So evaluation, again, very similar to a chest x-ray. Look at where these clavicles are. We got way back lordotic. So we've got low positioning, so we're centered on the lower portion of the T-spine and projected the clavicles way up above the apex of the lungs. And we exposed a portion of the patient we don't need to expose, and our result was just an ugly x-ray. So lateral, remember for a lateral T-spine, we're going to use a breathing technique. So it's very important to get the patient to get their arms out in front of them for a lateral. Just have their elbows bent to 90 degrees with their humerus pointed straight out in front of them. It gets the arms out of the way as much as possible. Keep in mind you're not going to see the upper portion of the T-spine, so we're going to have to do a swimmers on a T-spine series. On a C-spine series, we only did that as a last resort, but on a T-spine series, we always have to shoot one. We're going to evaluate the lateral T-spine similar to a lateral chest x-ray, only obviously on a lateral chest x-ray we don't want to see breathing or motion. On a lateral T-spine we're going to utilize the motion in the breathing to better visualize the vertebra. So shallow breathing, if you're on a limited exposure machine, what I'd recommend you do, if like let's say 1 second is as long as you can get for a breathing technique, have the patient take in a big deep breath and slowly blow it all the way out and shoot pretty much right in the middle of the exposure. That'll give you some degree of breathing technique. Otherwise, you just look like you have a high contrast lung chest x-ray where you collimate it in. So evaluate the posterior ribs for rotation, and that's your lateral. And what you're looking at for the lateral is the intervertebral foramina, and that's lateral T-spine and lateral L-spine both. So got rotation on this one, and you would evaluate rotation the same way that we talked about before. Gastric bubble, if you happen to see it, but heart shadow and all that plays into evaluation as well.